Hello, good evening, good afternoon, good day, good morning, wherever you are in the world. And thank you very much for joining the Black Belt Academy of Surgical Skills. My name is David O'Regan. I'm a cardiac surgeon in Yorkshire in the United Kingdom, and I'm the current director of the Faculty of Surgical Trainers for the Royal College of Surgeons of Edinburgh. For those of you who have been following us, welcome. Thank you for coming back. And for those who are joining us for the first time, I'm most grateful. We have over 2,400 followers and 1,750 likes. The more astute of you may perceive that our setup is slightly different. And that's because my wife asked me to move from one corner of the room to the other, so we have a different aspect. But the aspect this time is quite nice because my son's karate belts are hanging on the wall here, from when he was a white belt to red belt, with the various stripes, yellow, orange, green, blue, purple, brown, and black. And that is the principle behind the Black Belt Academy of Surgical Skills. He started shortly before his 5th birthday, and he's training for his 3rd down now, coming up to his 15th birthday in April. You can only become good at something if you practice. And on the wall here, we have evidence of his dedication and practice. And that's what I want to instill in you. I'd also like to take this opportunity of thanking Harris, one of our fans and followers, who sent me a wonderful video of his practice at home. I'll be putting that on the website to share with all the followers and others, because it was quite remarkable what he has done and is doing. We're almost at the end of lockdown in the UK, and hopefully returning to normal and getting back into the karate dojo certainly on the 12th of April. And I'm delighted that my colleague David Dickinson is going to open a Black Belt Academy of Surgical Skills dojo in Bradford, and I'm joining him on the 10th of March. We hope to be opening in Leeds and Sheffield and Hull and Liverpool shortly, and then progressing south. Well, tonight is all about the vascular anastomosis. And I suppose we should actually thank the Nobel Prize laureate, Alexis Carrel. Born in 1873 and died in 1944, he was a French surgeon and biologist studying at the University of Lyon. He was born to a very devout Catholic family, and in 1902 was cited as witnessing a miracle, which is subsequently disputed. But that left a cloud over his head, and he moved to America. And I suppose that's where his career took off. He worked with Charles Guthrie, a professor of physiology in Washington, and it was Charles Guthrie who actually wrote the book, Surgery of the Blood Vessels, and worked with Alexis Carrel. It is disputed whether Guthrie should have got the Nobel Prize, or should have certainly been shared with Carrel, but because Guthrie was advocating transplantation of the head, the Nobel Committee apparently decided he was off his rocker and this was a bit too far, and left it with Carrel. He also worked when he was in the States with a Charles Lindbergh, who came up with an organ perfusion system that is the fundamental basis of organ preservation and organ transplant as we know it today. He experimented with animal cells, and he claimed he came up with immortality with heart chicken cells, failing to recognize that the medium and culture that he is feeding these chicken heart cells with actually contains cells themselves, and he wasn't looking at immortal cells. But his work did define in biology the limit of divisions a healthy cell can make, and that is still used today. although his name is not on it. His work is there. He worked with an Englishman called Henry Drysdale Duncan, who was a chemist, and together they came up with a chlorine solution to clean wounds. And this is before the days of antibiotics. And Carrel and Drysdale used this chlorine solution to render wounds sterile. Carrel also talked about debridement, or since he's French, we should actually use the word debridement. But he also introduced mechanical irrigation. And mechanical irrigation for very bad sternal wound infection is still used today. And he was part of the Rockefeller War demonstration hospital. And his work on debridement and chlorine was apparently used extensively in World War I and saved lots of lives. But he was actually stimulated to think about vascular surgery and how to do it, because the president of France in 1894, who was, I'm just trying to find his name on my piece of paper here, sorry, Sadi Carnot, he was stabbed, and apparently this knife hit the portal vessel, and the French surgeons had a great deal of difficulty fixing the portal vein with the current suture material and techniques they used at the time. I can certainly attest to the fact that stitching veins is extremely difficult. And in fact, if you want to harm somebody, as Hannibal Lecter did in Silence of the Lambs, he took a Stanley knife to someone's groin. Cutting the artery is not a problem because you can press on it, but macerating the vein is a huge problem. And I remember a large 6'6" bouncer coming in to casualty with such an injury when I was training, and we couldn't stop the bleeding, and unfortunately this man succumbed. But it was Carrel who was stimulated by such an episode that spent 10 years from 1901 to 1910 experimenting on animals and describing all the techniques that we currently use today in vascular surgery. In particular, he described triangulation. They used fine silk at the time rather than monofilaments, which has somewhat changed our practice in vascular surgery. But I still, today, whenever stitching a vein, use triangulation technique with stays on either side of the vessel and at the heel and toe to hold it open to enable me to suture. Now, the most important principle that Carrel talked about, and we have tried to impart to you in this series, is respect of the tissue. Under no circumstances whatsoever should you be touching the intima of a vessel. And when you look at a vascular anastomosis from the inside, because that's where you'll see how good your stitching is, and the models I use in training, we always turn it inside out to look at it from the inside. You should not be able to see your sutures at all, and in fact, intima should actually meet with intima in a smooth, seamless process. So when I'm teaching how to stitch an aorta, I'm saying place your sutures from the inside and don't measure it from the outside, because although it might look fantastic on the outside, it doesn't necessarily translate to intima on the inside. And that is what we're looking for. So I'm going to take you over to the head cam, hold on tight, and we're going to discuss basic surgical skills related to vascular surgery and using the banana model. Now, many basic surgical skills courses start with putting a patch in an arteriotomy. But this is the basis of all fundamentals of vascular surgery, which is an end-to-side anastomosis. So this would be the side, the end of the vessel is stitched to this. And the principle of stitching, as we've talked about on our previous episodes, is that your needle needs to be placed at 90 degrees to the tissue at every part of this anastomosis. And you'll notice that with a curve, a vector changes all the way around this anastomosis. And the thing to be aware of is that the heel, which is proximal, and the toe, which is distal. Now, the heel and toe stitches effectively need to be a trident, like that, across the heel and toe. So that would be one direction, that's down the middle, and that would be another direction. Toe, one direction, there and there. And we could commonly refer to the anastomosis as a clock. But you can see, as I've drawn the vectors here, the needle at that point will be 90 degrees to the tissue. Okay? And as you're coming towards yourself, all the time, your needle needs to be 90 degrees to the tissue. At this point, you'll note that I'm now stitching into my right hand, and I need to go backwards. Now, there's a little trick for you here, and that applies to big vessels and coronary vessels, and the principles are the same. Whether you're dealing with a 2 centimeter vessel or a 1.5 millimeter vessel, the principle is exactly the same. Alignment of your needle at the heel and the toe is 90 degrees at the point, but actually that is parallel to the two walls of the vessel. And I would recommend holding your needle slightly further back, pressing your needle into the lumen, making sure you're underneath, and rotating your needle out. Okay? And that way you will never pick up the posterior wall. And it's a nice way of ensuring it. Now remember, the point of your needle needs to go through the full thickness of the vessel. And your needle should be lifting up the vessel as you're going round. Because if you don't use the point of the needle to lift up, you run the risk of running your needle through the wall. So the needle is rotated back, and in rotating it forward, make sure you're lifting it up away from the posterior wall. And every stitch is lifting it up. Okay? And you'll never, ever, ever hit the posterior wall if you stick to that principle. So remember, 90 degrees across what you want to stitch, rotate it backwards, and 90 degrees into what you stitch. And if it's 90 degrees, remember, it comes out at 90 degrees to the tissue holding it, deliver it iteratively through, pick it up in the right position, and bang, you through. Now, as you're going round, you'll note that the angle changes slightly. So one way of actually ensuring that your stitching is following the angles is just before I take it out, I'm picking up gently and nudging it slightly to give me that new angle there to allow me to continue. So you can go around this anastomosis as we did with a circular anastomosis and do multiple practices. But let's say we are going to go on to actually patch this. And this little bit of banana here, I've traced out in purple. That's the actual size. When you're patching a vessel, you don't cut something out the size of the hole, because all your sutures are going to have to be placed. And if you place your sutures there, you can see that immediately you start to constrict. Effectively, the patch you put on almost has to be double the size in many respects, because your sutures are going to be coming along this edge here. And you do not want your patch to constrict. Okay? Now, the other very important point is, when you're cutting a patch, is you do not cut it pointed like that. Okay? Because if you're stitching a point into an end-to-end, that will not match up and you'll end up with a bleed. Moreover, you're very likely to constrict the heel and toe, and this becomes extremely important on any vessel, but particularly those less than a centimeter, because then you're introducing a distal or proximal obstruction. But note, when you're cutting a patch, please cut it round at either end. It might sound counterintuitive, but it's important that that round end is stitched into the heel and toe properly. And you will note when you're doing it, it splays open. Now, Carell described putting a suture here, and you can work up this side, and tie it, work up this side, and tie it, and these could be stays. And certainly, when I started cardiac surgery, the surgeons I work with, Ravi Pillai, now sadly deceased, used to do exactly that on 2mm coronary vessels. Put a stitch in the bottom, tie it, stitch up one side, stitch up the other side, and he did this effortlessly in a smooth motion. I would recommend, however, we use a parachute technique. Now, I'm going to confess to you, trying to do a parachute technique by yourself without an assistant on a monofilament that, as you know, has got lots of memory, is difficult. And I confess that I tripped over many, many times. So the important thing is here, in cutting this patch out, I've cut it out bigger than that. And I start on the patch outside in, such that every suture on your vessel should come from inside out. Because if you come outside in on a vessel, you run the risk of separating the intima from the media and causing a flap. So every single stitch should come from inside and out. What it means is that you need to be careful in how you think of your stitching. And it's always better to stitch towards yourself and keep inside the loop of sutures such that you're not tripping over yourself. So when I'm putting a patch on or doing an Antiside anastomosis, I start at the heel, a little tight up here. I just wanted to get that straight. As I said, very difficult with one person. So I started outside in on the patch, inside out, outside in, inside out, heel, outside in, inside out, outside in, inside out. And I go 1, 2, heel 1. And I usually only put 4 sutures in. Okay, I do 4 sutures in on that. I'm going to just turn the light on. Does that help? A little bit. Yes. So I've got 4 sutures. And I don't put any more of 4 for basic parachute, because otherwise the tension in the parachute is lost. And parachuting is a skill. So you can see that I've got a number of strings there that looks like a parachute with all those strings. I take the patch down, I pull my parachute through, lift it up. I take it down, pull it through, lift it up. And you work it both sides. Take it down and pull it through, and I lift it up. Take it down, pull it through a little bit, not all the way, lift it up. And you gently tighten this all the way down. Pull it up, take it through, pull it up. And note that I'm not taking the vessel to the bottom, and I'm making sure that there's no loops, and you can see there it is going down. Okay, and as I said, it is awfully difficult as a one-handed surgeon to do this, and the important thing when doing any vascular surgery, your strings need to be straight. You would not play a violin, would not play an instrument with baggy strings. So doing an anastomosis one hand is awfully difficult. To ensure, if you need to do more than 4, then I'd suggest you use a nerve hook and take up the tension all the way through by lifting up the suture, taking up the tension and pulling it through each time, and make sure it's flat. Once it's down, remember that's inside, that is the outside. I can now continue my suture in the usual way. All right? But I would not advocate you going through both at the same time unless your needle's aligned to both. If it is, 90 degrees into, through, and you'll find that Dacron, etc. is very tough, and I would always advocate you do it in 2 because the tissue is actually, Dacron is actually very tough. My colleague told me he used to use grafts, and they weren't hemostatic, and he remembered doing a vascular graft, and because he hadn't pre-clotted the graft, he lost 1 liter of blood as a result of that. Fortunately, gel cell grafts and technology has come advanced that these grafts are hemostatic. Now the important thing is that your suture is everting, and by rotating backwards and 90 degrees into the tissue, remember in my first stitching demonstration, to take a needle through a piece of cloth at anything but 90 degrees is rather difficult because of the whop and wheeze. And that is exactly the same for tissues and Dacron grafts. And I hope you'll notice as we're progressing here that this cloth is now being everted, and you'll see why we needed to make the piece of cloth bigger than the arteriotomy. Now, although I'm putting a patch on, the principle of Antiside anastomosis is exactly the same. Imagine the patch and these edges were the edges of a lumen. Okay, so we had a 3-dimensional piece of cloth rather than a 2-dimensional piece of cloth, and then you have a lumen. So this exercise teaches you how to put sutures in and put a patch in. And note that only when you come to the end and you see that perhaps that the patch is somewhat bigger than necessary, it's only then can you look at what you got and trim. But I'm not going to cut the end anything but round, and I'll continue the round bit and I'll trim the patch up like that. And although it still looks on the generous side, I can promise you as I go through the rest of these sutures, this patch will sit very neatly on the banana. I'm just thinking that this is probably a YouTube, Facebook first, is a t-shirt patched banana, and nobody's actually done this before. Correct me if I'm wrong. And it is actually a rather fun exercise. Indulge me at the moment as I'm doing this. Note that I changed the weight of my foot and I've come backhand, and remember at the heel and toe, and I'll stop once we've got just beyond the toe. Without touching the needle, I corrected the angle of holding the needle further back so that I can get the belly to push the posterior wall away. Oops, too close to the tip and it sprung out the needle holder. There you go. Push the posterior belly away, posterior wall away with the belly, and lift the vessel wall up. Deliver the needle out carefully, and voila. We're almost around the toe. And the heel and toe I would actually do always into. Remember to line it. Now, is it 12 o'clock, 11 o'clock, 1 o'clock, or is it 10 o'clock, 2 o'clock, 12 o'clock? Really depends on the size of the vessel. But you can imagine if you separate it much more than that, the likelihood of having a toe or heel constriction is very high. There you have it. Vascular surgery in a nutshell. The angles, the rotation, the placement, the respect of the tissue is all there. And this was actually described by Alexis Carrel, Nobel laureate. Now, I've worked with a famous surgeon, Professor Samagda Yakub, and he was so famous that he was the answer to a question in a Trivial Pursuit. But Carrel is so famous that there is a crater on the moon, the Carrel crater, named after him. He also appeared in a Swedish postage stamp, but I don't think that carries as much weight as having a crater on the moon named after you. Please keep your pictures and your examples coming in. It's delightful that you're practicing. I look forward to seeing them, and I look forward to seeing you again next week as we continue our needle skills on a higher level and talk about getting your needle to work for you and dance on the end of your needle holder. Thank you very much indeed for joining the Black Belt Academy of Surgical Skills. I look forward to seeing you next week. Until then, be well, keep safe, and thank you very much indeed.